Hello, everyone. This is Siddharth Dambar from Chicago Arthritis and Regenerative Medicine. Welcome to our webinar today on regenerative medicine for arthritis, tendinitis, and back pain. Schedule this for about 45 minutes. I'll be talking for about 30 minutes. So if you have any questions, please send them over either in chat or in the Q&A section. And as we're going along, I will try to answer them. I do answer a lot of commonly asked questions, FAQs, as we're going through this, but please enter in your questions as we're going along. And like I said, I'll try to answer everything. Before we get started, if somebody in the audience could please just ping me and let me know if you can hear me clearly and whether you can see the screen clearly as well. You can see the slides. And of course, please let me know where everybody is tuning in from. Okay, great. So I've been told that I can be seen and heard clearly. Okay, great. Thank you. Okay, wonderful. Right, so today we're talking about regenerative medicine and how we're utilizing this in musculoskeletal conditions. So what you'll get from this webinar, you'll learn about what are the best available treatments for arthritis, tendinitis, back pain, and injuries that do not require surgery. You'll hear what is legitimate and not legitimate in the field of regenerative medicine, how to choose appropriate clinics and physicians who are offering these treatments as well. So, big question, what would you do if your pain was controlled? How would your life improve? What exercises would you restart? What activities with friends and family would you re-participate in? So who am I? My name is Siddharth Dambar, physician here at Chicago Arthritis and Regenerative Medicine. I know for some of the people who are tuned in, are people who already know me, patients of the clinic, and but there are a lot who do not know me. Specialist in rheumatology, specialist in image-guided musculoskeletal injections in practice since 2008, utilizing regenerative medicine since 2008 and within the Regenix network, which is the largest network of physicians who are involved in regenerative medicine since 2012. So my own personal journey in regenerative medicine. So I used to play a lot of tennis when I was in high school, quit as a young adult, restarted in my early 30s. And it turned out playing as a mature adult is a little bit different than when you're playing as a teenager. You start to find some interesting injuries. My shoulder had started to hurt around that same time. I started to learn about diagnostic musculoskeletal ultrasound. And I learned a lot about my own shoulder, and I started to look at anatomy very differently. And I started to realize that the way that we're treating tendon and ligament injuries is really not very good, not sufficient, and that there's a lot of room for improvement. And so that got me involved in platelet-rich plasma, and then eventually into the Regenix network, and then utilizing treatments like bone marrow aspirate concentrate stem cells. So traditional care is really insufficient when it comes to treating arthritis, joint pains, tendinitis, tendon tears, sprains and strains, and back and neck pains. And really it's because the primary first and second line treatments are very much just mask the pain and then eventually waiting for surgery, some kind of replacement surgery. And that is the equivalent of if you took somebody that has early diabetes, then waiting until they had their first heart attack or stroke, meaning not doing any kind of intervention with either diet, exercise, or medication. That's still how we're treating arthritis and tendinitis, really waiting until things just completely fall apart. And there's definitely a scope to do better. So problems with traditional care, pain medications, they don't fix the problem. They have lots of side effects that we really frequently ignore, but that people do suffer from. A lot of the traditional injections, whether it's steroid injections or nerve blocks, they have other side effects. Steroid injections can damage tissue, increase the risk of infection, diabetes, osteoporosis. Nerve blocks and radiofrequency ablation, which are frequently done, are essentially treatments that sort of burn the nerve to help with pain relief. The problem is that they lead to nerve damage. That's actually how it works, which can then lead to muscle weakness and other side effects as well. And so while it can help with pain, those kind of treatments don't really help with the long-term nature of what people are dealing with. Surgery is appropriate in cases where things are too far gone, but routine surgery, which is what's really done here in America for a lot of things that are not really at that level that require surgery, have higher risks. They can accelerate the arthritis process. A lot of arthroscopy surgeries like knee arthroscopy actually accelerate arthritis. They're not really fixing the problem, especially if you already have early arthritis. They can lead to more instability. Again, a lot of routine surgeries that are done without significant proof. In fact, 80% of musculoskeletal conditions that are traditionally done with arthroscopic surgery can avoid surgery. Study came out from the UK a few years ago that showed that 75 to 80% of surgeries that are done for orthopedics are done without very high level 1 evidence. And so a lot of that is because, we haven't had traditionally good options for people. And some of that is just because that's how practice has been. And so we're looking for better options. So searching for better options, those options need to avoid those kind of side effects that we talked about that are lower risk, improve the actual cause of the problem, and have the potential to offer a long-term improvement. So imagine reducing your pain and getting back to the activities you care about without surgery or pain medications. So regenerative medicine is the process of utilizing your own body cells to treat arthritis, tendinitis, injuries, and back pain. This utilizes a normal healing process. The normal healing process essentially is after an injury, you have platelets and other cells that enter that area of damage. They release growth factors, which then leads to inflammation, which then leads to stimulating your own local stem cells in that area, which then leads to that normal healing process of damaged cells. In tissues that have poor blood flow, that includes tendon, cartilage, ligaments, labrum, menisci. The problem is that they don't have that same normal healing process because they don't have good blood flow. So regenerative medicine is a process of taking those cells that are involved in that healing process and then utilizing high-level X-ray, ultrasound guidance to then help deliver those cells into that damaged tissue. So why regenerative medicine? Number one, it treats the source of the problem being instability, inflammation. It's safer than surgery. It's effective for most musculoskeletal conditions. And again, 80% of traditional orthopedic surgery will eventually be managed by regenerative medicine. The way to really think about these treatments is the same way that at one time, all cardiac issues were treated either with neglect and then eventually open heart surgery. Now the vast majority of cardiac issues are handled either through medication, diet, exercise, and if needed, needle-based procedures that are not open heart surgery. And now really only the most extreme things are handled with open heart surgery. Eventually, that's how orthopedic surgery will be. So how does regenerative medicine work? We're essentially optimizing damaged cellular health of tissue. And that means that cells that have been damaged in either tendons, joints, ligaments, that when you re-expose them to your own platelet growth factors, your own mesenchymal stem cells, they start to work better. You're able to help previously damaged cells to start producing the right sort of proteins and enzymes that you see in a healthy joint or tendon. In addition, if you add stem cells into a tissue with damage over worn out stem cells, you get those existing cells to start functioning better. In addition, we know that what drives pain is not just a damaged cartilage cell or damaged tendon cell. It's also improving all those other supportive tissues. And that includes ligaments, other soft tissue structures. As you strengthen those supportive structures, and I'll talk about this a little bit more in a moment, you actually help with pain and function longer term as well. Understanding that what's problematic is the entire unit, which is more than just a cartilage cell that may be damaged. It's treating all those other cells as well. In addition, we know that these kind of treatments, while they lead to inflammation short term, long term, they reduce chronic inflammation, and that's what helps with pain. In addition, we can help with neuromuscular health, which helps to reduce irritation in nerves, which reduces inflammation of compressed nerves and improves stability long term as well. So regenerative medicine basics, things that a very brief FAQ, but number one, is this legal? Really, the simple answer is yes, but the more complicated answer is if you're following the guidelines from the FDA, it's legal. And really the key things when it comes to guidelines are, number one, you have to be using your own cells, not somebody else's cells. Number two, the cells cannot be significantly altered or adjusted. Number three, you need to inject these into orthopedic tissue. So while you may hear about research that's being done for other conditions, hearts and lungs and kidneys, those are not approved by the FDA at this time. And frankly, I'm not an expert in those conditions. But when it's coming to treating arthritis, tendinitis, injuries, and back pain, these are definitely approved when followed those guidelines. Another common question we get is, if I'm older, shouldn't I use someone else's cells? And the answer is no. For the majority of orthopedic conditions that have been studied, there's good evidence that using your own living cells is effective and appropriate. And the reason for that is, number one, there's additional risk when you use someone else's cells. Number two, and so when it comes to other risks, when you inject somebody else's living cells, your body reacts to that, like it's foreign tissue, like it's bacteria or viruses. And so there's risks to that. Number two, understand that in this country, it's illegal to inject somebody else's living cells into yourself. The exception being if you have certain childhood leukemias and cancers. So is there an age limit? Again, short answer is no. The results for knees, lower back, shoulders, elbows, ankles, and neck are not impacted by age. Hip outcomes can be impacted by age as you start to get over 60, 65 years old though. So what sort of doctor should do these treatments? What I'd recommend is, number one, your doctor should be focused on musculoskeletal conditions. Realistically, if your doc is doing 10 different things, meaning they're injecting Botox in one room, they're helping somebody with their erectile dysfunction in another room, and then they're manning a urgent care on the side, and they just happen to see a few knees and lower backs, that's not an expert. Number two, they should be focused on non-surgical treatments for orthopedic conditions. Orthopedic surgeons are trained and experts in surgery. They're not trained to do these kind of treatments that require image guidance as well as experience with these kind of needle-based procedures. And then lastly, they should be a proper regenerative medicine expert, which I'll talk about in a moment. So can these treatments help if I've already had surgery? Shorter answer is yes. However, if the joint's already been replaced, then you've already cut out the tissue that's involved. Your pain may be coming from other structures, but we wouldn't be injecting cells into an area that now has metal or plastic. So general rules that I recommend for patients for orthopedic surgeries, number one, if possible, try to keep your own anatomy. Try to avoid surgeries that are strictly cutting out tissue, and always consider a regenerative medicine treatment option if you've been recommended surgery. But make sure you talk to somebody who knows what they're talking about so that you're getting an appropriate opinion. So key things when it comes to regenerative medicine, which I'll talk about, is number one is stability, number two is orthobiologics, and number three is interventional orthopedics. This is really how you tell if someone knows what they're doing in this field. So stability is key when it comes to the musculoskeletal system. There's this concept of biotensegrity, which essentially means that if you take a structural unit, and this really comes from the architectural world, but is applied to the biologic world as well. If you take a structural unit, the individual units may be weak on their own, but when you put them together and compress them, you get a structure that's a lot stronger. So prolotherapy is the idea that by injecting cells into soft tissue supportive structures, you can strengthen and stabilize the unit, the overall structural unit, in a more stronger way. So what that means is if you have, let's say, knee pain, you don't want to only treat the knee joint. You want to treat the ligaments around the knee, the tendons, the fascial structures, even the bone at times. You want to treat everything that's impacting in that in the structure and stability of that unit. And so understanding that when it comes to treatment, you need to treat layers and depth of that tissue. Number two, also understanding that these treatments progressively improve over time, because by treating those other supportive soft tissue structures, it takes time for those things to get stronger. And then understand that that leads to a longer lasting result long-term as well. So this is a case study to kind of explain that. This is a 71-year-old man, chronic lower back pain. He's had prior surgery of the lower back in the past. In his case, we ended up using platelet-rich plasma and platelet lysate to treat the ligaments of the spine, the facet joints, the muscles, and the epidural space. He had mild improvement to begin with. We then escalated to using his own bone marrow stem cells, which now has given him a more durable impact for the last 4 to 5 years of about 75% improvement. The key things to understand here are, number one, treating multiple tissue structures to treat that overall unit that's problematic, not just treating the epidural space. I'll talk a little bit more about the different types of cells that we use, but understanding that you have to treat those different levels is important. So orthobiologics are the kind of cells that we use. It's a biologic cells and tissues that are injected into orthopedic tissue. It utilizes that normal healing process. Again, understand that you want to use your own cells, not somebody else's, because there are too many risks with using somebody else's. So how does this work? After an injury, take something as simple as cutting a cut on your finger. You have platelets that come into that area. Those platelets recruit other cells, and those growth factors then help to stimulate your own local stem cells. It leads to focused inflammation initially, and that focal inflammation is what then helps to repair tissue damage. So some of the most common orthobiologics that we use, platelets are really the most common one. Platelet-rich plasma is a process where we take a sample of your own blood, concentrate into a high concentration of platelets, and then re-inject that. Platelet lysate is another version of that, but where we're now cracking open the cells and just extracting out the growth factors and injecting that. So if you look at the picture on the right, there's two different types of platelet preparations here. The platelet preparation that's orange or amber colored, that's basically platelets that we've removed all the red blood cells, which causes inflammation, and now we're left with just your own platelet growth factors and platelets. That's the kind of platelet-rich plasma you want. The platelet-rich plasma on the right, where you have a lot of red blood cells, is not the kind that you want. Those red blood cells are not helpful when you inject it into tissue or tendons. It's actually damaging and causing too much inflammation. If you have this treatment, you want to make sure you're getting the kind of platelets that you have on the left side, which is that amber-colored platelets. Also understand that it's important to understand that when you're getting treated, the sort of concentration of platelets that they're using should be varied based on the kind of tissue that's being treated. You want a very high concentration for when you're treating your joints, moderate concentration for tendons, and then a low concentration for ligaments and nerves. And so if physician or clinic doesn't have that kind of subtlety, you probably want to be looking elsewhere for treatment. So this is a case study. This is a 45-year-old man, cyclist. He's a triathlete, originally presented with left knee pain. He's actually referred to me by a sports medicine physician because of persistent patellar tendinitis. So when we say patellar tendinitis, what do we mean by that? So the picture on your right is an ultrasound picture. This is the kneecap here. This is the white structure of the kneecap. This is the patellar tendon. And this is where you got the tendinitis. So in his case, he had platelet-rich plasma. He actually had two treatments. The picture on the right is a picture of the needle injecting directly into that patellar tendon. He's back to full capacity, full activity level, and doing very well. 3 years later, he actually presented with hamstring tendinitis on the other leg. We treat him with platelets again, and again, he's back to high-level activity. So in this picture, this is the needle injecting into patellar tendon. Key to understand that to inject something like this, you want to be doing this under high-level ultrasound guidance. Make sure you're hitting the right tissue. In addition, great thing to understand here that in this gentleman's case, he required 2 treatments of platelets. And what's nice about these kind of orthobiologic treatments is that they give you a longer lasting result. And if you end up getting a repeat treatment, you're now building off of that first treatment. So you got that sort of stair-step improvement over time with longer lasting results. And then as you need to treat something else in that person, treating, let's say, the other leg or the other knee, being able to safely treat someone again is really important. So stem cells, that's the main stem cell. That's the main cell that drives tissue repair and recovery after an injury. Again, understand, use your own cells, not somebody else's. In the United States, what's legally allowed are utilizing your own bone marrow-derived stem cells. And the reason for that is, number one, there's clinical studies that go back to the mid-90s for using bone marrow stem cells. Fat stem cells are not legal in the US. You can use fat adipose for structural support. You cannot use that for a stem cell treatment. And the reason why for that is because in order to get the cells from your fat, when you're using what's called stromal vascular fraction, you have to use an enzyme that the FDA thinks is not safe in humans. There is good evidence that fat stem cells can work, but you really cannot find this in the United States at this time because of that concern about that enzyme. You've probably heard about amniotic and umbilical cord cells. You may not be hearing too much about that right now just because the FDA is clamping down upon that. There's no living cells in these tissues. Essentially, the way that these tissues are prepped immediately after birth, that tissue is then taken to a lab. The lab then, in order to make it safe for human use, then basically pulverizes the tissue, gamma radiates it, which kills off all the cells. They then pack it into a glass vial. You have powdered material that's put into a glass vial, which is then shipped off to the physician's office. That can sit on the physician's shelf for 2 years. When it's used, they then rehydrate it by putting some saline or water back into it, and then they re-inject it. There's growth factors in that, and it can help with some soft tissue injuries. There's no living cells in it, and so it's really not a stem cell treatment because there's no living cells. IV stem cells, you may have heard about this in other countries as well. There's no proven benefit for orthopedic conditions. May help for things like hearts and lungs, but again, that's kind of beyond my scope. In addition, not legally allowed in the United States. So what can we expect when it comes to stem cell treatments? Number one is improving pain and function, even frequently in advanced cases. And the reason why is that, number one, we can help improve stability by treating all those other supportive tissues. Number two, by treating chronic inflammation. We know these treatments can reduce inflammation long-term, which helps with pain. In addition, if you have cells that have been chronically damaged, we know that re-exposing them to your own platelet growth factors or stem cells can actually help to get those cells to start functioning better. And then lastly, what you see in someone that's had chronic pain or a chronic musculoskeletal issue is that people start to lose their exercise tolerance, their ability, which then leads to weakness, which then leads to more pain. And that as people's inflammation comes down, stability gets better, pain gets better, they're then able to start doing more activity. They start reversing that cycle. And as their exercise tolerance improves, the strength gets better, the supportive tissue gets stronger, and then on its own, people start to get better long-term. So can we improve X-ray and MRI images? So for advanced arthritis, no, we cannot change what that image looks like. For tendon tears that are small, we can improve what the images look like. For ligament tears that are small, less than 2 centimeters, we can do that. If you've got swelling in the bone in arthritic joints, that can improve as well. If you have what's called avascular necrosis, that can improve as well. The key thing to understand is that even though in advanced arthritis, X-rays and MRI images don't change, people's pain and functional level does clinically improve significantly over time. And in the end, that's really what's most important, not just improving how your images look. With that said, I'll show you some images that actually do improve. So can we treat bone-on-bone arthritis? So this term bone-on-bone arthritis it's just a terrible term because it doesn't really mean anything from a clinical standpoint. Frequently, I'll see patients that will say that they've been told that they have bone-on-bone arthritis in the knee, and yet they can still flex their knee all the way back. And so, truly, if you have bone-on-bone arthritis, you shouldn't be able to have that kind of range of motion. So I think a better way to really understand arthritis is that it's a biologic condition and that is treatable with orthobiologic treatments. And if your range of motion and function is still fairly intact, you can still get good outcomes, even if you've been told you have bone-on-bone arthritis. Again, caveats: advanced hip osteoarthritis can be more challenging. And I think you have to always focus when it comes to arthritis, more advanced arthritis, on pain and functional improvement, and less so on imaging. So can tendon and ligament tears be treated? So this is a nice case study of someone who has an ACL tear. For partial thickness tears, yes. For full thickness tears, as long as the tissue is still closely approximated, yes. If you have a tendon tear where the tissue is fully gapped and pulled apart, then that's unrealistic. That's a surgical case. But even in surgical cases, applying your own bone marrow cells or platelet cells can be beneficial. So this is a 28-year-old man. I'm giving a case, describing a case. He had an ACL tear while playing recreational volleyball. He's actually a butcher. He's not a professional athlete. So in his case, he ended up getting bone marrow aspirate concentrate 2 months after his injury. At the 3-month mark, he's no pain and restarting dynamic exercise. What's really great about his case, and I'll show this to you, is just how much better he got in terms of imaging as well, which is pretty cool. So the image on the right is an X-ray, and that's his kneecap, that's his thigh bone, that's his shin bone. This is a needle going into the ACL. What's lighting up here with a little bit of contrast is his anterior cruciate ligament. That's what's been torn. You're only able to really do this kind of treatment under really high level X-ray guidance. So this is his MRI, and this is really pretty amazing. So his pre-treatment MRI, like his injury MRI, is on the left side. That's his ACL. Normally an ACL should have a nice kind of linear appearance to it. This one, just very swollen. The radiologist has described this as a full thickness tear without retraction of the ligament. That's right there. On the right side is his post-treatment MRI. So this is his MRI after he's been treated with his own bone marrow stem cells. Now you have a structure, and this is 3 months after treatment, so about 5 months after his initial injury. This is a very linear, clean-looking structure, ACL. So in his case, he's got not only an improvement in his pain and function and stability, he's also got improvement in his actual image as well, which is pretty amazing. This is a case study of a 57-year-old man. He's a contractor. He's got a full thickness tear of his rotator cuff, and I'll show you what that looks like. He was treated with his own bone marrow stem cells. And again, back to not only work and activity and exercise, but I'll show you his ultrasound pictures as well. So the pictures on the left, this is pre-treatment ultrasound, pain with overhead activity and at nighttime. This gap right here, so this is the rotator cuff tendon. You can tell it's been chronically dinged up just based on how it looks. There's a gap in the tendon, that's where the tear is. This is kind of a more dramatic look to it, that gap in the tear. This is 3 months after activity. He doesn't have any pain with activity now or sleep. Here's that filled in tissue now, 3 months after. And he's doing great. And that's the kind of result that ideally we're looking for in someone who's got this kind of tear. And this is a tear where this is a full thickness tear, but it's a tear where the tendon isn't fully pulled back. So that's why he was able to respond to treatment. Before I go on, somebody asked a good question. What can be done about advanced hip arthritis at the age of 74? Realistically, it depends on how bad it is. If you've got, at that age, if your hip arthritis, what we know about hips is that they're different than knees. Knees, even if you've got advanced arthritis, regardless of your age, you can still respond very well. For hips specifically, if you've got advanced arthritis, you're over the age of 70, and your range of motion is limited, you should consider replacement at that point. On the other hand, if you're 74, if your range of motion is still intact, then that may be something that can still respond to treatment. But you have to kind of go into it thinking that it may be a harder case just because of age and degree of arthritis. So interventional orthopedics is this idea of using image guidance to treat orthopedic injuries, meaning using your own cells and doing it under ultrasound and X-ray guidance. So show you a couple pictures. So this is an example of two different shoulders that were treated. So this is the rotator cuff. This is the needle. We're treating somebody's very small rotator cuff tear with his own platelets. What's important to understand here is this tear, this size of this tear, this is very small. This is a few millimeters, but that's what's causing his pain. And in order to treat that, you have to have a very high level of ultrasound guidance. You can't do this blindly. I have colleagues who say that they inject and treat this just with palpation without any image guidance. And to treat something like this, that's just a millimeter, couple millimeters in size, that's nonsense. You can't do that blindly. This is an example of treating somebody's shoulder on the right side of with his own bone marrow. That's the needle. This is the shoulder joint here. It's a little bit of contrast showing that we're in the joint and then we're injecting cells. This little triangular structure up here that's lighting up as well. That's an example, that's his labrum. Again, that's a very small structure. In order to treat that, you need to be very precise and you can't do that blindly. You need to use X-ray and ultrasound guidance. Again, this was some knee pictures that I'd shown before as well. The one on the left is of the patellar tendon. The one on the right is of the ACL. Again, these kind of treatments can be done, but when you're injecting your own cells, you have to be very precise. And as I tell patients, until I have X-ray vision, I'll be relying on utilizing the imaging modalities that we have, whether it's ultrasound or X-rays. It's an example of someone who's got avascular necrosis. Avascular necrosis means where the bone is limited blood supply and is starting to get damaged or eventually even die. So this is a 41-year-old man. He's a chef. He stands at work for 12 hours at a time. He's developed pain and swelling in his ankle due to wear and tear arthritis, as well as avascular necrosis. So we did the 3-step stem cell protocol in his case. 3 months later, again, pain is dramatically better, back to work, and his MRI images have really resolved that avascular necrosis. And he's about 3 years out and he's 95% improved still. So the picture on the left, this is pre-treatment MRI. That's a little bit of fluid in the joint. In the bone here, this is avascular necrosis that's developing in an earlier stage. 3 months after treatment, the bone has completely changed color because that avascular necrosis has been treated and the fluid in the joints resolved as well. So somebody just asked, how is avascular necrosis determined? It's determined based on X-rays and MRI. You can basically determine how bad that level of avascular necrosis is. If the bone is swollen, but has not kind of crumbled, has not sort of fallen apart, then we can still treat this non-surgically. If the bone has started to collapse and it's kind of crumbled, then replacement is generally what's recommended at that point. Okay, someone else asking about their hip arthritis. This is someone in their 50s. Yeah, great question. Absolutely. What you're describing in terms of hip, knee, and lower back, that's something that can definitely be treated. Obviously we need to evaluate your actual images as well as speak to you about your degree of issues, but that's something that can definitely be treated. Regenerative medicine treatments offer safe and effective solutions for your pain. So is this too good to be true? So number one, there's evidence of this that really goes back to the mid-90s. Dr. Philip Hernigue, he's a orthopedic surgeon in France. He's been treating shoulders, knees, and hips. He's got studies where he compares patients, same patient will treat one knee with surgery, one knee with his own bone marrow stem cells. The Regenerative Network has data that's since 2005. And the evidence shows that in the right situations, in the right candidates, people can do very well with treatment. Experience, I have colleagues who'll say, there's not enough evidence for these kind of treatments. And I would disagree with that. This is definitely a rapidly developing field. I have personal experience since 2008, but I have colleagues that have been doing this since 2005 or the mid 1990s. This is not a new field. It's just one where there's not a lot of people that have appropriate experience. And in experienced hands with appropriate data, you can pick the right people for these kind of treatments. There's definitely right and wrong ways. There's a lot of wrong ways. And if you do it the right way and give people appropriate expectations grounded in reality and evidence-based medicine, these are very much appropriate treatments, and they're definitely not too good to be true. How long do results last? So Regenerative has data that's up to 10 plus years. Philip Hernigue has data that's over 20 years. I still tell people, be conservative in your expectations. And what that means is if you have a chronic condition, expect repeat treatments at some point after a few years after initial treatment to continue your success from treatment. What's the best way to maintain results after treatment? Number one, improve biomechanics that caused the problem to begin with. Absolutely. There's certain supplements that we know that can help with joints. We recommend those all the time: omega-3, glucosamine, and curcumin. And again, if needed, repeating treatment is additive to that initial treatment and is a good idea if you have a chronic condition. Cost. So not routinely covered by insurance, the exception being for patients whose employers are self-insured and have added the Regenerative corporate plan to their benefits plan. If your employer is one who has that option, check it out at regenerativescorporate.com. There's about 500 plus companies that currently cover these treatments in the United States. If not covered, here's some cost estimates to expect in the US. This is kind of throughout the country amongst colleagues. PRP is about 1,500 plus. Stem cell treatments are generally 7,500 plus. I think the keys to determine value, strongly recommend this. Number one, is the physician and clinic doing this a regenerative medicine expert? Have they been doing this for many years? Are they using evidence-based treatments? Are they giving you realistic expectations of treatment or pie in the sky expectations? Are you receiving a real stem cell treatment or something that doesn't have living cells like amniotic or umbilical cord cells? Again, to me, that is in large part a matter of physician education. If they're not educated appropriately, if they're not an expert in this, they may be giving you incorrect advice. Also understand that for the most part, these are in-office procedures. You can avoid hospitals and surgery center facility fees, which can really drive up the cost for these procedures as well. I think some things to mention about how we try to approach patient care here at Chicago Arthritis and Regenerative Medicine. Number one, very focused strictly on non-surgical treatments for your arthritis, tendinitis, injuries, and back pain. When it comes to evaluation, always things that we focus on are, is there inflammation, instability, asymmetry, neuromuscular issues? Try to correct things always with low-risk interventions first. If not working, then recommend regenerative medicine treatments. Always focus on using best quality products from your own body. A plan that is specifically tailored for your condition and needs, meaning what is the treatment for you is not what the treatment for the next patient is. It's very much focused on your needs, and delivering cells using the highest level of image guidance to give you the best chance of a appropriate and ideal outcome. I see there's some questions coming in, so I will get to that. How do I get evaluated? Probably easiest way is to go to Chicago Arthritis and Regenerative Medicine. If you have questions, we're obviously here to help and answer. Okay, somebody asked, what is PRP? And somebody answered back, it is platelet-rich plasma. Thank you. So again, platelet-rich plasma, or PRP, is utilizing your own blood platelets. Really kind of the base treatment for regenerative medicine, and a good option for a lot of conditions that we use, that we treat. Somebody asked, are these procedures covered by insurance? I answered that. Traditional insurance does not cover this, but Regenerative corporate plan does cover this if your company is self-insured and if they add it to their plan. Is regenerative medicine offered only to patients of a certain age group? Nope, depends on your issue. Again, if you can't exclude people just based on age. Number one, the evidence shows that for a lot of conditions, age does not make any difference in terms of outcomes. Number two, we have people who are 80, 90 years old who are still incredibly highly active, who are exercising 7 days per week, who probably have a biologic age more like of a 50-year-old. On the other hand, we have 20-year-olds, unfortunately, in this country, who probably have a lifestyle that have a biologic age of a 60-year-old. And so I think you really have to look at the individual and decide what kind of candidate they are. Somebody asked what non-healing, slow healing bones. They had a sprain and avulsion fracture. Yeah, it's interesting. So a chronic non-union fracture, like non-healing fracture, is some of the first things that were treated utilizing bone marrow aspirate concentrate, bone marrow stem cells. So that is something in the right case that can still be treated. I don't personally treat those kind of injuries, but I have colleagues in the Regenetics network that do. And if you need a referral to that, we can help out with that. But that is, in the right candidate, something that can still be treated, actually. All right, somebody else asking about how good are my stem cells if I have an autoimmune condition? Great question. I'm probably one of the few people that have a lot of experience in autoimmune issues based on my training in rheumatology and treating patients with rheumatologic conditions, and also regenerative medicine. And what I have found is that if your overall inflammation and autoimmune condition is under control with treatment, then if you still have like a residual couple of joints that are active, that can still respond very well to treatment. A couple of caveats to that are, number one, if you're taking a lot of prednisone or steroids, that can block the effectiveness of treatment. Normally, if you're on a lot of steroids, it means that your overall condition is not under good control, and you probably need to be on some other medication to get you off the steroids. Number two is, if you're, with the exception of prednisone or steroids, your other meds that you're using for your autoimmune condition, you should continue those in the setting of treatment, because that's partly what's controlling your condition. And so having an autoimmune condition does not prevent you from getting treatment, because you can still respond very well, but you need to make sure that your autoimmune condition is optimized and in its best state. I hope that was clarifying. Wonderful. Well, that is everything I have to present. And if there's any other questions, please let me know. Again, if you have any other questions, you can reach us at chicagoarthritis.com. And I appreciate everyone's time. Thank you for the kind words, Mr. Function. If anyone else has any other questions, you can reach us at the website, chicagoarthritis.com. And of course, there's always that last question that comes in. Will taking turmeric have any effect on relieving ankle pain from arthritis? It's a good question. So curcumin or turmeric has been shown in various arthritic conditions. The most study has been knee arthritis, that it can help with pain. It can help reduce the amount of anti-inflammatory meds that you require in comparison to commonly used anti-inflammatory medications like ibuprofen and Advil. Curcumin or turmeric has been shown to work as effectively for pain relief. So I would utilize it. I think when you think about low risk interventions for pain, whether that's omega-3, curcumin, turmeric, or glucosamine, I like low risk interventions, whether that's supplements, whether that's exercises, Pilates, yoga, massage, chiropractic, Egoscue. Like low risk interventions are always helpful, and I think a good option, especially if it helps you avoid surgery, helps you avoid chronic pain medications as well. Great. Well, thank you very much, everyone, for your time. I'll leave the webinar on for like another minute or two. If there's any other questions that come on, even if we can't answer them live, we'll make sure that somebody reaches out to help answer them for you. And if we can help out in any way, please contact us anytime. And I hope everyone has a good week and stay safe and stay healthy. Thank you.